Well, we're going to get started. But first, we'd like to thank everybody for joining this unique Welfare and Safety Summit. The past 8 Welfare and Safety Summits have been conducted in person at Keeneland. We thank the Jockey Club and the Grayson Board of Directors, and obviously Keeneland for their support of them. Even though we canceled this year's in person, we've wanted to continue with some webinars. We're going to try to do them in an hour long, and your Q&A button at the bottom is open, and we'll answer questions at the end. So as you're listening to the presentation today, if you have any questions, just go ahead and list them online there. Our first presentation today and our first webinar, our only presentation today, is going to be Dr. Katherine Garrett from Rood and Riddle. Dr. Garrett received her DVM degree from Cornell University. Following graduation, she completed her internships and surgical residency at Rood and Riddle Equine Hospital in Lexington, where she is now a shareholder. She's a diplomat of the American College of Veterinary Surgeons Large Animal, and her practices focuses on diagnostic imaging. Dr. Garrett's going to talk to us today about fetlock injuries and specifically the Palmar metacarpal disease and how various imaging modalities can be useful to diagnose it. So without any further ado, I'll bring on Dr. Garrett now.
Great. Thank you so much for the invitation to speak here, and thank you everybody for coming. I'm really excited to be able to talk to all of you today. All right, let's get this going. All right, so hopefully everybody can see my screen. So as Jamie said, I'm going to be talking about diagnostic imaging of the racehorse fetlock, but in reality, diagnostic imaging is a huge topic. So I'm not going to be able to touch on everything by any stretch of the imagination. So I'm going to describe the different imaging modalities that we typically use in horses, then do a brief review of anatomy and imaging of injuries of the fetlock region, and then just a little bit of a focus on palmar osteochondral disease of the distal metacarpus as an example of how we use all of these imaging modalities. So one really important thing to keep in mind is that we need to interpret the results of our imaging studies in light of the clinical examination. We are never just treating images, we are always treating an actual horse. So just because we find an abnormality on an imaging study, it doesn't mean it's significant, because we find lots of things that aren't really relevant to this particular horse at this time. So one of the difficult questions to answer, and it can be really difficult sometimes, is which abnormalities are clinically significant to this particular horse. So that's where we bring in our clinical examination in combination with our diagnostic imaging. So really they're going hand in hand. The major goal of imaging is to come up with an accurate diagnosis. And once we have an accurate diagnosis, we can use that to create an appropriate directed treatment plan for this specific problem. Rather than kind of doing a scattershot approach, we can be targeted in what we're trying to help this horse with. So with that, let's talk about some of our imaging modalities. So if I could design an ideal imaging modality, I would, but I can't because right now it is currently a unicorn. But if I could design it, an ideal imaging modality would be inexpensive. It would be very quick to acquire, a matter of minutes. We would be able to perform it at the barn or the stable. The horses wouldn't have to come to the hospital. It wouldn't require general anesthesia, and it would be highly accurate. And honestly, probably a better way to refer to highly accurate in an imaging sense would be that it would have an enhanced diagnostic ability. So with that in mind, we have 6 major imaging modalities: radiography, ultrasonography, nuclear scintigraphy, also known as bone scan, MRI, CT or CAT scan, and then PET, which is a relatively new imaging modality. So let's see how each of those modalities stacks up in our 5 desired attributes. So starting with radiography, one of its great strengths is that we get good general images of bone. So right here we have an example of a condylar fracture, and this radiograph demonstrates that beautifully. It's relatively inexpensive, and radiographs can be acquired at the barn. And especially with the advent of digital radiography, a lot of times we can make a stall side diagnosis. Not always, but sometimes. Some of the challenges associated with radiography is that it is not as sensitive as CT or MRI for bony problems, and it gives us limited information about soft tissues. But the take-home message for this is that it is a really good initial choice for bony problems. Ultrasonography is another modality that you're probably familiar with, and it gives us really good information about soft tissues and bony margins. So for example, this is the superficial digital flexor tendon here, and this black area here is a small tear. It's also inexpensive, and we can acquire this at the barn or the racetrack. It's not as sensitive as MRI is for soft tissue problems, and it can't image deep to bone or air, so we can't see what's actually going on inside of a bone using ultrasound. But the take-home message for ultrasound is that it's a really good initial choice for most soft tissue problems. Moving on to our cross-sectional imaging modalities, the first one we'll talk about is MRI. So because of these cross-sectional images, we're able to get high detail because we're looking at very thin slices of tissue. So we don't actually have to deal with superimposition the way that we do with, for example, radiography. It gives us superior information about tendons and ligaments, cartilage, bone bruising, and other types of bone damage. In the horse, we can only image the limbs from the carpus or tarsus, so knee or hock distally, and they do need to come to a hospital, and some systems require anesthesia. So MRI is a really excellent choice for soft tissue and bony injury. Our other cross-sectional imaging modality is CT, and it also gives us cross-sectional images with that same high detail, but CT really excels when looking at bones. So here you can see some of those examples, and we have this very nice reconstruction ability like you can see in this fetlock. So this is essentially a real-life example. So if, for example, you're thinking about a complex fracture, that reconstruction ability can be very, very helpful. Again, similar to MRI, we're limited to the portion of the limb that we can image, and compared to MRI, there's more limited soft tissue information. And you also do need to bring your horse to a hospital or a clinic, and anesthesia is required for some of these systems. So take-home message, CT is a very great choice for bony injury. Now, moving on from those were structural imaging modalities, so it gives us information about the actual structure of the bone. We have two modalities that are functional imaging modalities, and so that tells us essentially what the bone is doing. So the first one we'll talk about is nuclear scintigraphy. And what this does is it tells us information about bony turnover. So where in the skeleton is there increased bone turnover activity? And because we are able to image the entire skeleton in one session, it takes a couple of hours, but it's feasible. It is a really good screening tool for bone problems a lot of places in the skeleton, including in the fetlock joint like we see here. So the challenges are that it's relatively low resolution, so it requires an additional structural imaging modality, for example, radiographs, for a more precise diagnosis. It gives us very limited information about soft tissues, and this does need to be performed at a hospital or a clinic. So scintigraphy is a great choice for stress fractures or other injuries that involve increased bony turnover. And then PET scanning, which is a relative newcomer, this is our other functional imaging modality. So it also evaluates bony turnover in a similar way as scintigraphy, except we get much higher resolution and cross-sectional images. So that enables us to localize where the problem is a lot more precisely. There's been a scanner developed that does not require general anesthesia, which is nice. And again, we can really only image from the carpus and tarsus distally, and the horses do need to come to the hospital. We don't have as much information on PET scanning as we do on some of these other modalities because it is much newer, but there's a lot of really interesting work happening, and hopefully this is going to be a great tool in our toolbox. Okay, so now that we've talked about each imaging modality individually, let's see how they stack up against one another. And remember, ideally, we would want it to do all of these things in that left-hand column. Well, surprise, surprise, none of them can do everything. No one has green check marks in every single column. But if we look at radiography and ultrasonography, they shine essentially in the convenience and expense categories. And to be very honest, most of the time we can make a diagnosis using radiography or ultrasonography. I mean, there's a reason that they are so common. It's that they are generally very good, but they aren't quite as good, and so sometimes we do have to move to our more advanced imaging modalities. So looking at the modalities that have this enhanced diagnostic ability, oftentimes they cost a little bit more, and the horse needs to go to a hospital or a clinic to have these provided, but the trade-off for that is you're going to get the answer that you need, ideally. All right, from there, let's move on to some fetlock anatomy and just review what we're looking at when we look at these imaging modalities, because honestly, a lot of diagnostic imaging is about knowing your anatomy. So the fetlock is an amazingly complex structure for something that's about the size of your fist. And it contains all of these different structures here. And we're not going to talk about all of them, but there's a whole lot more to the fetlock joint than meets the eye. So starting with the bones, there are 4 major bones involved in the fetlock joint. So there's the cannon bone, which is the 3rd metacarpal bone, the paired proximal sesamoid bones, and then P1, which is the long pastern bone. And now if we think about the soft tissues that overlie those bones, there's a lot of soft tissues, but today we're going to focus more on the suspensory ligament branch. And remember, the suspensory ligament starts right below the knee at the proximal part of the cannon bone, and then inserts onto the top part of the proximal sesamoid bone, and then the distal sesamoidean ligaments, which originate at the bottom of the proximal sesamoid bone and extend down into the pastern region. So just to hone in a little bit more on the fetlock joint surface, we know that we have the bones, but then right over the surface of the bones, right there in that red line, we have the articular cartilage, and that's what is actually lining the joint. So the bones don't articulate right against one another ideally. It's the articular cartilage that's touching one another. So right here, this white line, that shows where the articular cartilage is. And then the bone that's immediately deep to the articular cartilage is known as subchondral bone, so just bone that's immediately deep to the cartilage. But these 2 structures are right there on the joint surface, and they're very important in some of the diseases that we'll talk about later. And then we'll talk a little bit about Palmar condyle disease. So to just go over exactly where that is on the fetlock, it's right here on the bottom part of the condyle of the cannon bone. So if we rotate this bone around, you'll see where the cannon bone, the sesamoid bones, and P1 are. And again, that's where we're looking right on that palmar condyle. And then if we look at an example where P1 has been moved away from the cannon bone, it's that spot right there. So just to the side of the sagittal ridge, we have this area of the palmar condyle on this side as well as that side. All right, armed with that anatomic information, let's talk about some common injuries to the fetlock region. So dorsoproximal P1 chip fractures are a relatively common injury that you're probably familiar with. These usually occur from accumulation of repetitive trauma to the bone, and radiographs are generally sufficient to diagnose this. We don't usually need our advanced imaging modalities. A lateral condylar fracture, like we see here, this is another injury that occurs from accumulation of repetitive trauma to the bone. And again, radiographs are generally sufficient to make this diagnosis. Moving on to a soft tissue injury, suspensory branch desmitis is a relatively common injury in the racehorse. And here we see the suspensory ligament. This is the cross-sectional view, and this is the longitudinal view. So this is outlining the whole suspensory ligament, and then these arrows right there show that darker area of damage, and ultrasound does a really good job of making these diagnoses. When we talk about suspensory branch desmitis and sesamoiditis, what we're talking about is a disease at the junction of the suspensory branch, which is a soft tissue, and the proximal sesamoid bone, which is a bone. So what we're looking at is, here's the bone right here, and then we see this loosened area right there, right where the suspensory branch is inserting. So that's the bony component of the injury. And then with the ultrasound, we can see the soft tissue component, this darker area here and here. So this is a good example where we use paired modalities to get both sides of what's going on with this particular horse. Distal sesamoideal ligament desmitis is another soft tissue injury, and oftentimes ultrasound is sufficient to diagnose. Like right here, this is the oblique distal sesamoideal ligament there, and here we can see we've got some bony fragments associated with this injury. But sometimes if the injury is very subtle, sometimes we do need MRI. So there's that oblique distal sesamoideal ligament seen there, and these little bright areas right here, those are areas of injury, and you can see they're much brighter than this opposite side right there. Okay, so now let's focus in a little bit more on one disease known as Palmar osteochondral disease, also known as POD or POD. So the first thing we'll talk about is where is it? And it happens on that area of the distal palmar condyle of the third metacarpal bone or cannon bone that we were just talking about. So this is that area that we circled on the skeleton, and then this is an MRI image and then a bony specimen. These are the same horse. So we can see here, out here, this is relatively normal. This is pretty normal. But then right here on this area of the condyle, we have an abnormal area in that subchondral bone that we talked about before. So the reason is that this is an area that is subject to very high forces during racing or race training on a repetitive basis. So this is the stance phase of the gallop. You can see how how the limb looks on the horse. And then in this diagram, you can see this part of the cannon bone is right where the proximal sesamoid bones are articulating when the leg is in this position. So right when there's a lot of force on that limb, this vulnerable spot in the cannon bone is undergoing a lot of those forces. So why does it happen? And one thing we need to remember and kind of back up and think about is that horses, or any animal, in high intensity exercise like race training, they adapt their bones in response to the repetitive loads that we place on them. And this is a normal process. It's known as Wolff's Law. So if you want a bone to become strong at race training and adapted for that, you need to train the bone to know, okay, these are the forces I'm going to ask of you. And bones are incredibly smart, and they will adapt in response to these loads. It takes time. You know, this doesn't happen overnight. It can take days to weeks to a couple months. And ideally, the bone makes those adaptations and can keep up with the training load. And this balance can be a little bit difficult to strike. And we don't always get it perfect, unfortunately. So POD develops when there's an imbalance between the work that is being asked of a horse and the horse's ability to adapt the bone quickly enough. So essentially, the bone can't keep up. And what this does is it leads to chronic subchondral bone fatigue, like we see here. And then the pain, which manifests as lameness, results from this damage to the subchondral bone. But there's really a spectrum of changes to the bone. This isn't, you know, it's normal one day and it's abnormal another day. Because this is part of a normal adaptive training process, we expect some of these changes. The problem occurs when the bone isn't keeping up enough. So it's essentially a normal process gets a little bit out of hand. So let's see some examples of this spectrum of changes. So this is the normal fetlock joint, and in the top set of images, pay attention to the subchondral bone, which is this black rim right here, and in the bottom set of images, pay attention to the articular cartilage, which is this white right here. So this is a normal fetlock joint. So as horses undergo race training, they will get sclerosis, so this dark area. And again, this is a normal part of a normal part of training. When we start to get that imbalance, you can get some necrosis right in this palmar condyle. So that bright white rim right there within the dark, that's when we're starting to see some of that maladaptive change. If things keep going and get worse, you can actually have collapse of the subchondral bone. So this dark subchondral bone area has actually collapsed inwards. And you can see a little bit of that down here as well. And then if things progress further, there can actually be a fracture. So you can see this fracture line exiting the bone there, and you can see it right there where it's fractured through the cartilage. So you can see there's a wide spectrum of changes that are associated with this. Now, one of the things that is very frustrating is that there is no clear answer as to when the bone isn't keeping up. and when those changes cause lameness, because there is a ton of individual variation in the middle. So you can't just look at a set of images and say, this horse, can keep training and this horse needs a break. It's definitely not that simple, and you really need to pay attention to the individual horse itself, because we can say, okay, this is okay over here, and we can say, okay, this is not okay over here, but in the middle, there's this huge gray area of individual variation, and the fact that we know that we have to subject these bones to training, and there will be changes as a result of that training, and as a whole, the changes are good. That's what trains the bone. So obviously we care because this causes lameness. And in severe situations, it can lead to permanent joint damage. So if you have very, very severe POD, there tends to be an association with generalized osteoarthritis in the fetlock. However, it's important to remember that there is usually a very good prognosis with just simple turnout. So giving the horse a break, not locking it up, but turning it out so it can move around and remind that bone that still needs to think about being an athlete, as long as there's not very severe damage. So this isn't one of those situations where if your horse has this problem, it's all over. Usually most of these horses come around. So how do we diagnose this? Like I said, you have to look at the horse. So a lameness examination with blocks that allow us to isolate the source of pain to the fetlock region are very, very important. And from there, once we've done that, we can move on to diagnostic imaging that allow us to identify changes in the bone. And we're looking for structural changes that we can find with radiography, CT, and MRI, as well as functional changes that we see with scintigraphy and PET scan. So starting with radiography, we can see this spectrum of changes in these two horses. In the horse on the left, we just have some very subtle lucency in that condyle, in the area that we're talking about. Whereas in the horse on the right, we see that fracture type of line. So the spectrum of changes is well represented by these two sets of radiographs. Before we move on to CT and MRI, I just want to say a quick word about how we look at these cross sections, because honestly, it can be confusing. So in looking at this three-dimensional model of the leg, one set of slices that we take are called transverse or axial slices, and these are kind of like slices in a loaf of bread. So they're slicing the leg from top to bottom like a loaf of bread. Another set of slices are side to side, and those are called sagittal images, so that one in the middle. And then the last typical view that we use are dorsal images, where you're looking sort of in slices from front to back. So with that in mind, here's an example of a horse with some relatively minor areas of lucency, so those darker areas that we see right there within an area of sclerosis, which is whiter. So that's relatively subtle, but then we can see a larger spectrum where we have a more obvious lucency and a larger area of sclerosis. So again, a spectrum of changes. MRI can show us those same changes. So here we have a more subtle case. And then down here we have a horse that actually has one of those fractures right there. Okay, so moving from our structural imaging modalities to our functional imaging modalities, this is an example of a horse's scintigraphic scan. So right there we can see this area of increased uptake where it's darker, and that's right in that Palmar condyle area. So as I said before, oftentimes we need to combine this functional modality with the structural modality, and in this case we can see this abnormality here on the radiograph right there. And then PET scan, like we talked about before, it also gives us functional information, but it gives it to us in a higher resolution way, as well as in a cross-sectional way. So here we can see areas of increased uptake, those yellow dots. And when this information is combined with the CT scan, that structural information, and then fused together, we can see that those areas of increased functional activity, increased bone turnover, are the same areas where we have the structural change that we can see on the CT exam. So this is a nice way of combining a structural and a functional imaging modality and getting a lot of information. So we do need to respect that the different imaging modalities have different abilities to detect the structural changes in the bone. And radiographs are good, but they are not great at detecting the changes. And that has to do with two major factors, one of which is superimposition of adjacent bone. So unlike MRI or CT, we can't get those thin slices. Instead, we get sort of a three-dimensional image that's been flattened into 2 dimensions. And it is less sensitive to the subtle changes than MRI and CT are. And that's not that radiographs aren't good or aren't valuable. They are very good and they are very valuable. But MRI and CT are really excellent at detecting these changes. And sometimes we do need that extra bit of detection ability. So to illustrate that point, all of these images are from the same horse. So this is a radiograph, and you can see a faint lucency here in that condyle. But then when we show the CT and MRI of this same horse, the abnormalities are more apparent using these advanced imaging modalities. We can see a subtle change on the radiograph, but everything is much more obvious on the cross-sectional imaging modalities. So one question that often gets asked is, can imaging predict lameness and injury? Can we use some sort of imaging modality to sort horses into those who can keep training and racing and those who need a break? And honestly, the answer right now is no. The frustrating and major reason why this is there's a lot of overlap in the changes that are seen in a normal response to training and those seen in a pre-lameness or injury state. There is a ton of variation between horses. So one set of images, one horse will be lame and another horse will be training really well and go on and win a stakes. That's part of why we need to treat the actual horse and not just the images. And also, it's a lot easier to diagnose an existing problem where a horse comes to you and someone says, this horse is lame, I need you to find the problem. That's a lot easier than trying to predict a future problem out of a huge population of horses, most of whom aren't showing lameness or some other sort of problem. So right now, I don't think that we are near to any sort of technology where we can currently predict lameness or injury. But we would love for someday that to happen or to get better at that. So it's an area of investigation, and my suspicion is that CT, MRI, and PET scanning will play major roles in some of these endeavors. But I don't think there will ever be a clear-cut answer to this. There will be no magical sorting mechanism, and no test is 100% accurate. A lot of tests are very good, but asking for 100% accuracy is a lot. And we really always have to consider the horse itself, not just images. There's no magic machine that we, put the horse on a conveyor belt and it goes through and outspits the answer. That unfortunately is just not really the way the world works. So I would be happy to answer any questions. If I can get my screen share back. Let's see. I think I did that correctly, Jamie, but please tell me if I didn't.
Yeah.
Okay.
Yeah, we've got a few questions actually.
Great.
The first one is, what are the costs associated with the different modalities? Now, you don't have to get specifics about your individual prices at Rood and Riddle, but
Right. So in a ballpark price, a set of radiographs of the Fetlock region will probably cost you a few $100s. A CT or an MRI is probably more in the area of $1,000 to $2,000. PET scan has really just become available, and I don't really think it's like in the truly clinical stages where we have costs, but my guess is that it would be in the thousands of dollars range, maybe $1,000 to $2,000. Bone scans typically between $1,000 and $2,000. Don't hold me to them, but those are some of the general costs. So, there is more cost associated with these advanced imaging modalities, but I think sometimes it's important to remember that it's about the most efficient way to find the answer, not the cheapest way to find the answer. Because if you end up with the wrong diagnosis, you can end up spending money in the form of treatments or money in the form of time going down the wrong road when maybe getting, the more accurate diagnosis at the beginning could have saved you either money or time. So efficiency as opposed to cost, I guess, is maybe a better way to think about that.
Yeah, and you had mentioned there's no magic image for what we're
No.
going to do, and a lot of the questions are centered around, well, why can't you run it through this machine and or run it through this modality or this imaging? And can you just talk a little bit more about all that goes into the training you've had, examining the different imaging, and then sometimes you can do a horse with all different modalities and get different results, and how the angles and all the little
Yeah, it's a big question. So essentially, the images that you get are only as good as how you acquired them. So if you take a radiograph and it's at a really weird angle and it's not hitting the part of the anatomy that you need to look at, well, then it's not helping you answer the question. So ability to acquire the images in a high quality way is so important. And especially to look at the Palmar condyle that we've talked about so much, you have to do some special angles with your radiographs that, I mean, to be honest, they're a little bit physically challenging to get the horse to do, and they're kind of picky. But the benefit of that pickiness is that you're able to really highlight the part of the image that you want. And so the changes that we're looking for, they're really subtle, and it takes a fair amount of experience to know, well, what does this mean in general, and then what does this mean to this horse? That's part of the not just a science, but also an art part of veterinary medicine, I guess I would say. And then the other frustrating part is you can have two images from two different horses that look very similar, and one horse will be lame and one horse will be totally sound. And so again, that's some of that art, because not all the horses respond the same way to training and what we ask of them. So that's why it's not so simple as, I mean, even if it weren't up to the human eye, the same amount of pixels can mean different things to individual horses. So it's kind of like that Venn diagram. Your circles can overlap kind of a lot sometimes, if that makes sense.
Yeah, it does. And then where is the most common location of the stress fractures that we see lead to catastrophic injuries inside of the?
It's most commonly, so you see the fetlock joint, and they're most commonly right on the sides of the sagittal ridge. So hang on, let me go back to my little diagram. We'll see if we can get there. And let me find the image that I'm looking for. Let's see, let's use this one. Okay, so this is the fetlock right here, and this is looking from the front. So this is the sagittal ridge right here. So most often we see changes right to the side of the sagittal ridge, like right here on the three-dimensional image, or right here on the transverse image, or right here on the dorsal image. And those are the ones where we worry about, can those progress to a condylar fracture?
And is that the areas when you hear the phrase bone bruising? Is that also where you're seeing that?
That's one of the areas. It's all of this Palmar condyle area that we worry about. And I mean, it's just these horses are undergoing, I mean, they are truly tremendous animals, and really kind of a marvel of Mother Nature that they can stand up to these loads on their skeleton.
So here's another one. Are there many cases where the horse doesn't exhibit lameness, but POD is present?
It can be. It's not as common, and some of that may be, maybe the horse isn't manifesting a large degree of lameness, but that's a good example of where we need to treat the whole horse, not just its images. I mean, if I saw images and I saw, a lesion on them, I would want to investigate, maybe if someone says, yeah, I don't think this horse is lame, maybe take another look and see if there is some subtle lameness present. But, sorry, go ahead.
No, and a follow-up question to that is, would you back off training, jogging, or give complete rest, send them to the farm for carpal bone disease?
Okay, so carpal bone disease is, not the fetlock, but we're essentially talking about the same sort of injury. It's this repetitive stress injury. So what we like to do is send them to the farm, give them, usually 2 months is a good amount of time, not locked up in a stall. You turn them out as much as they can, because then they're actually out there, being horses. They can move around, they can run around a little bit, they can walk, they can eat grass, they can do all that sort of stuff. So, because if you lock them up, essentially you're detraining that bone. Because remember, the bone says, I will try and do what you ask of me. And if you ask of the bone, sit in a stall, the bone's like, okay, well, I guess I, need to demineralize some of this stuff and take it away because I don't need it anymore. And that's not what we want ultimately. We don't want to overload the bones, but oftentimes turning out isn't overloading the bones, but it's still enough to keep that skeleton thinking.
Here's one probably from a veterinarian who's watching. Are there unique radiographic views, flex views, that you find most helpful to evaluate horses for POD?
I think this veterinarian might be sitting a couple rooms away if I had to guess. But yes, there is one flexed view that is extremely helpful. And I'm going to illustrate this poorly, but essentially you bend the leg kind of like this. And what that does is it lets us lift the sesamoid bones up away from this area of interest on that palmar condyle so that we get much less superimposition. So it's a way to compensate for the inherent limitations of superimposition by getting those sesamoid bones up and away so that we're really highlighting exactly the part of the joint surface that we're curious about. So, that flex VP projection is, my fetlock is not so good. But by doing this, you're moving the sesamoids up and highlighting that part of the joint without superimposition and in a way that you can best evaluate it. So for example, we always include that view when we're looking at racehorses because we know that that's such an important spot to look.
And I guess that's what they're seeing without the flex in the PET scan when it appears the heat on the bottom of it. That's the same view that they're looking at, right?
So, sort of, but with the PET scan, because it's 3 dimensions, you can essentially peel away everything you don't want to look at. Mm-hmm. So that's one of the beauties of 3-dimensional imaging is you don't have that superimposition. So that's why with the radiographs, we do that view in a specific way to get that angle, whereas with the PET scan, we can cut it up and slice it in all different directions.
Okay, and here's a couple related to bilateral lameness. It says POD lesions are bilateral for the most part. If they are sore in both contralateral limbs, don't they usually have more of a subtle gait abnormality rather than an obvious blockable lameness in one limb?
They certainly can, and one way that you could approach that would be, if you think that's what's going on, you could block the condyles on one leg and see, once you've removed the pain from that one leg, you could see how that affects the lameness in the opposite leg, then block that leg, and then hopefully, assuming that, that's your only lameness problem, then hopefully the horse should look a lot better after you've blocked both of those sites on both legs.
Yeah, and this one you just do. Sometimes you need to examine both legs in case of lateral lameness.
The horse will tell you.
And here's the next 2 questions are kind of related to 2-year-olds. This one looks like an international viewer and says, do trainers in the U.S. routinely scan their horses' legs, particularly with respect to 2-year-olds, to see how the bone is adapting to training to prevent any further injuries occurring?
I don't honestly know the answer to that question. I don't work on the racetrack. I would certainly imagine if there's a problem, they would look into it, but I honestly don't know what a lot of people's different protocols are.
Yeah, and some more age related. How does the age of the horse fit to those common diseases you were talking about earlier? Do you see 2-year-olds with X and 5-year-olds and older horses with Y? And, how's that work?
Well, one classic example of a young horse disease that we see are bucked shins. And that's a good example of another one of these, training the skeleton and, a mismatch in what you're asking of the horse versus what the horse's skeleton can accommodate. But sort of an interesting thing is it's important to train horses when they're young, not too young, but training a 2-year-old, is great because you're still training that skeleton. And if you wait and you don't start training a horse till it's 4 years old, you still have to train that skeleton the same way as you would if you started when the horse was younger. And there's been work that's shown that, you know, 2-year-olds have horses that train and as 2-year-olds do very well.
And that leads me to the last question, I believe, which is regarding the misconception that racing and training as a 2-year-old is detrimental. Equestrians and some other disciplines often criticize racing industry for training racing horses at an age because in other disciplines they wait until they're older to begin training. How would you respond to them as the environment we face in racehorses, or the horse is accustomed to doing?
Yeah, I mean, I think it's important that we talk about it because, I mean, that's why we're all here. I mean, we care about horse safety. And one of the important things to note is that training 2-year-olds has actually not been shown to be detrimental at all. In some cases, horses that have trained as 2-year-olds have had better careers when compared with horses who did not train as 2-year-olds. So that's important to keep in mind. It's also important to keep in mind what racing as a sport is very different than, let's say, dressage as a sport. So what we, and I am not a professional racehorse trainer or a professional dressage trainer, so keep that in mind. But what we're asking these horses to do, it's a very different set of skills that we're trying to develop in a dressage horse as compared to a racehorse. But I mean, I really do believe this pretty strongly, is that most people really want to do the right thing by the horse. And I think that's true of whatever discipline you're in. But I don't think we have not shown detrimental effects. In fact, we've shown some positive effects of training 2-year-olds as opposed to waiting until they're older.
And then final question, and we'll let you out of here unless there's any others that are typing while we answer this one. But so a horse or a trainer contacts you guys and says, I've got a lameness. I think it's in the fetlock. It's an older horse. He's been gone through. He's not a stakes horse, but he's a mid-level claiming horse, but I still want to do what's right. Where do you start? What do you do?
So the best place to start with something like that is a lameness exam. We look at the horse, we watch them jog and walk, straight lines, circles, all those sorts of things. We do flexion tests to see, is the range of motion limited? Does the horse have any pain when we flex anything? Are any tendons and ligaments, do they feel thick or are they tender? We'll jog the horse after each of these different things. And then if the horse shows no lameness, well, great, fantastic. If someone is still concerned about poor performance, if the horse just isn't right, well, then maybe we need to look somewhere else. Maybe we need to scope its stomach for ulcers or, something like that. But if the horse is lame, then we'll start with our diagnostic blocks, eliminating different areas of the horse's skeleton to see if we can find the source of the pain. Once we've found the anatomic location of the pain, we'll move on to diagnostic imaging to get a nice, precise diagnosis, and then come up with a treatment plan. So, the way we typically approach things here is, with a history like that, we start with a lameness exam, figure out where the problem is, then figure out what the problem is, and then figure out how we're going to go from there.
All right. Well, I don't see any other questions. And we certainly appreciate your time. And
thank you so much for having me.
The use of the Rood and Riddle surgery suite over there. And if we have any follow-up questions or we get email, I'll contact you, and we appreciate your time again.
Yeah.
Thanks so much.
Thank you so much.
Yeah, thank you. Thanks everyone for tuning in. We're going to try to do these. We've got some more scheduled. Next week, we're going to have a veterinarian panel. Dr. Dion Benson from the Stronach Group is going to talk and lead a panel and moderate about the importance of transparency in medical records and the ever so important monitoring horses between starts. We're going to have Dr. Will Farmer, the Equine Medical Director at Churchill, Dr. Scott Palmar, the Equine Medical Director at New York State Gaming, and Dr. Ryan Carpenter, who is a practicing veterinarian out in California, has worked with Dr. Benson a lot on some of their new rules. And that'll be next week at 2. Same link, but if you want to be reminded, just email us over at Grayson and we'll send out reminders on the day before and the day of. And we appreciate your time, Dr. Garrett. Thank you guys so much.
Anytime. Thank you.
Thanks, everyone.